Good afternoon, everyone, and welcome to today's webinar, Equitable Rebuilding from COVID-19, Strengthening Protections for Communities, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on the Network's website shortly after the conclusion of today's event. We strongly encourage attendee participation, so feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. We'll be addressing them towards the end of today's event. Your moderator for today's webinar is Kathy Hoke. Kathy is the director at the Network's Eastern Region Office and a professor and director of the Legal Resource Center for Public Health Policy at the University of Maryland Carey School of Law. She'll be leading us through the rest of today's webinar. So Kathy, over to you.
Thank you, Charles. We've done so many of these webinars together, but it always is nice to hear you remind us of how we do the Q&A and the chats. We all think we've been doing this for so long, but different platforms and the like. So if anyone has any questions while this is happening, put it in the chat and Charles will certainly resolve it for you. So thank you for the introduction of me, but more importantly to this webinar. And thank you for joining us this afternoon or this morning, depending on where you're joining us from, for the Network's webinar, Equitable Rebuilding from COVID-19, Strengthening Protections for Communities. When I was asked to moderate this webinar, I was really excited about it because while none of us were excited about the pandemic, right? It was a horrible thing that has happened, that is happening. But we can at least look forward in a hopeful way that we can rebuild our communities in a more equitable manner. And that's what you're going to hear from our presenters about today, ways that we can take advantage of this huge disadvantage that was put upon our public health system. So you're going to hear from three presenters today. First, our pinch hitter, Peter Jacobson, who co-directs our Mid-States region in Michigan, was under the weather. And so Abby Lynch, who is a legal researcher with the Network's Mid-States Region Office, has stepped in. Abby is a legal researcher with our Mid-States Office, and she earned her JD from the University of Michigan School of Law and her MA from the University of Buffalo. And we want to really express our gratitude to Abby, who is taking a break from bar study to join us. So this may be the best part of her day, so maybe she's happy to join us. Then you'll hear from Sabrina Adler. Sabrina is the Vice President of Law at Change Lab Solutions, one of our favorite partners on the West Coast. She works primarily on legal and policy issues related to preemption and good governance, the commercial determinants of health, and healthy children and families. She's co-authored publications and presented on many issues, and I can say it's been many because I do follow Sabrina, but at the intersection of law and public health, including sugary drinks, food policy, preemption, and health equity. And then we will round things out with our very own Dawn Hunter, JD-MPH, who just for a couple of more days will identify as the Deputy Director of the Network's Southeast region. She will become the Director effective July 1st when Jean Matthews takes a tiny step back and lets Dawn's light shine even brighter. So prior to joining the Network, Dawn served in a variety of roles focused on public health, policy, and health equity. She has worked in state public health at the New Mexico Department of Health, where she started as a Robert Wood Johnson Foundation visiting attorney in public health law, which was through the Network. So we knew her as a baby lawyer, and now we get the advantage of having her as a tremendous asset to our team. She also served in New Mexico as the Director of Health Equity, the Policy Director, and the Deputy Cabinet Secretary. Dawn has taught us all in the Network so much about health equity, and I'm grateful to have her as a colleague. So on that note, I turn things over to Abby.
Good afternoon, everyone. I'm going to be starting us off today with a discussion of executive decision-making in COVID-19 and how equity considerations have been incorporated into states' responses to the pandemic. So just as an introduction, executive decision-making is the crux of using law to achieve public health objectives. And problems can arise when executive decision-making is used only to achieve the immediate public health goals. Because when that's the case, we sometimes let equity considerations fall by the wayside, and our long-term objective of achieving health equity can suffer. And public health officials, who can range from local health officers to state governors acting in emergency situations, have a big role to play, not just in protecting the public's health, but also in promoting health equity. We all know that COVID-19 has negatively impacted health equity by disproportionately affecting racial and ethnic minorities and other vulnerable populations, and it's exacerbating existing healthcare inequities also. State executive branches have had to use their legal authority both to prevent the spread of COVID and to mitigate these inequitable impacts. And for example, there are many ways that states have had to take complementary actions to provide relief to those who have borne a disproportionate share of the impact of COVID-19 restrictions themselves. So the very efforts to try to prevent the spread of COVID-19, states have had to provide relief for those inequitable effects, and they have an ethical duty to do that. So when we talk about executive decision-making, we're talking about the broad discretion that public health officials often have in determining what actions they should take. And because they often have such broad discretion, they should always ask, can I, must I, and should I before acting? Can I covers whether they're legally able to take an action that they want to take. Must I asks if action is in fact mandated, whether by law, by funding requirements, or some other mechanism. And should I is where the real meat of kind of public health decision-making comes in. It's typically a discretionary policy question, and it often involves scientific and political considerations, considerations of evidence-based practices, those sorts of things. And importantly, it should also involve a consideration of public health ethics. And the public health ethics value of distributed justice is where equity considerations come into play. And distributive justice basically says that the burdens, the risks, and the benefits of public health actions should be fairly and equitably distributed among groups of individuals. So there's also a tension between effective public health response and the ethical consideration of equity. When immediate public health action is required, ensuring that there's an equitable distribution of these risks, benefits, and burdens may not be possible. For example, there are actions that have an inequitable distribution of risks, benefits, and burdens, and those actions may be required to avoid further endangering the public health. For example, in COVID-19, the orders to close businesses and schools have burdened low-income individuals disproportionately, but they also have helped to reduce disease in the entire population. Situations also may require a choice between two options, each of which presents inequitable burdens on either different populations or they burden the same population but in different ways. So sticking with the business and school closures, those again may burden low-income individuals, but the increased spread of disease that might occur in their absence may itself have had a disparate impact on the same low-income individuals or on other vulnerable populations. And then finally, actions to ensure equitable distribution of benefits and burdens may not be legal, as they may violate the Equal Protection Clause of the United States Constitution. And the Equal Protection Clause requires equal treatment, but the problem is it doesn't require equitable treatment. For that reason, an action that tries to ensure equity among racial groups, for example, and therefore treats different racial groups differently, would face strict scrutiny if it appeared before the courts in a challenge. And so it's for these reasons that while ethical considerations should be included in the process of executive decision-making, they cannot be expected to dictate the results. So turning to how states have approached executive decision-making and equity considerations in COVID-19, myself and two other individuals looked at an 8-state sample to see how states responded to COVID-19 equity issues. We looked at 4 states with Republican governors and 4 states with Democrat governors, as you can see on the slide. And we explored how these states' executive branches use their legal authority to respond to pandemic caused inequities, and this was as of February 2021. And we found 3 trends. The states with Democrat governors developed initiatives that focused on COVID-19 equity issues. The majority of states, regardless of governor, participated in at least one such initiative. And then all of the states, to varying degrees, took other executive actions to directly address inequities. So referring to the trend of developing initiatives focused on equity, initiatives in this area were of 2 primary types. They were either driven by state action or driven by community action. So for the first example, Michigan's Coronavirus Task Force on Racial Disparities studied racial disparities that emerged as a result of COVID. It makes recommendations to address them, and it performs community and stakeholder outreach. Colorado had a similar health equity response team that also focused on data availability, coordination of resource and logistics, and policy recommendations. And then 2 states focused on community action-driven initiatives. Maine was an example of this with their Health Equity Improvement Initiative. And that initiative reimbursed community-based organizations who were working in minority communities to educate on COVID-19 and its prevention in culturally sensitive ways. And Wisconsin had a similar initiative that provided grants to community organizations to support COVID response and recovery and resiliency building in communities of color. To the trend of participation in COVID-19 equity initiatives, most of the states participated in the Reskilling and Recovery Network, RRN. The RRN was a nationwide partnership between the National Governors Association and the American Association of Community Colleges. And you can see the map of all the states that participated, denoted in purple there on the slide. And the goal of this initiative was to increase low-wage workers' skills to help them obtain unemployment and to address equity issues. So it was focused on people who lost their jobs as a result of COVID and getting them retrained to enter the job market, perhaps in different ways than they were previously employed. And then the trend of other actions to address inequities, these were mostly targeted on providing relief directly to individuals in the population. So you can see there's a lot of examples on the screen. I'm sure you're familiar with many of them. States designated as essential businesses, groups that provided services to populations in need. They took actions to assist renters and homeowners in paying for renter mortgages and preventing evictions. They implemented worker protections. Really, they took a lot of actions that provided relief directly to individuals. We also identified some state equity, and 3 examples were a failure to timely implement bilingual COVID briefings in areas where there was a large population of non-English speakers. There was a state that ignored explicit calls from people of color to take actions to address inequities. And then there was a state that only provided COVID testing centers in a particular minority area after intense community pressure to do so. The state did not recognize ahead of time that that was something that it needed to do. And it took a lot of advocacy to get the testing center where it needed to be. So the overall takeaway on public health officials' efforts to promote equity that we have learned from COVID-19 is that public health efforts to promote equity in pandemics can vary. It can vary in the actors responsible for driving efforts, whether that's the governor or state agencies or some other group. And it can vary in method, whether that's collaborating with communities in the work that they're doing and providing them assistance, or if it's giving direct assistance to individuals. There are lots of different ways that states and public health officials can act. Second takeaway is that resource constraints are likely the biggest obstacle to providing relief to populations in need. States all receive federal funding to respond to the COVID-19 pandemic, but by and large, funding was inadequate to provide all the needed assistance and to address all the health equity issues. And so states can't depend solely on federal funds to relieve and prevent inequities. And this goes to the next takeaway, which is that public health officials have to think creatively about how they can promote equity in each step of emergency response. And they need to think creatively about this. For example, they can find ways to work with those who maybe do have access to the resources needed to address inequities and find creative ways to partner with those individuals. So our overall conclusions are that public health officials first have to determine what actions they need to take in order to prevent the public health. Once they have the actions that they need to take, equity should be considered in weighing the options and evaluating the trade-offs and the different ways to go about those actions. And then to the extent possible, the actions that are selected should attempt to produce inequitable results, or at the very least avoid exacerbating existing inequities. And for those actions that do produce inequitable results, there are often ancillary actions that governments can take to kind of ameliorate those inequities. So then we ended with recommendations for state and local governments, and I won't read these word for word, it's a lot of words, but basically states and local governments and public health officials need to incorporate equity considerations into their decision making, and they should encourage other members of government, public health or otherwise, to do the same. It's crucial that we collect and analyze complete and accurate data in pandemics, and that we collect that data by race, ethnicity, age, socioeconomic status, any of those groups that we are concerned about potentially being inequitably burdened. Equity considerations should be considered when planning public health emergencies, and they also should be examined in after-action reports to see how we can do better next time. And I think I will leave it there, and I think that Sabrina will be presenting next. So thank you all for your attention.
Thanks, Abby. So I'm going to talk about how preemption factored into the pandemic response and how it has largely harmed public health efforts, worsened health inequities, and underscored the need to reform and rebalance the relationship between state and local government. So quickly, for those who aren't familiar with us, ChangeLab Solutions is a national nonprofit. We are based in Oakland, California. We work on equitable policy to improve the health of communities. We have an interdisciplinary team. So even though I'm a lawyer, I also work with policy analysts, land use planners, and others. And we provide technical assistance training and model policies across a wide variety of subject matters, as well as on health equity and good governance more broadly. Just a quick disclaimer, I'm not providing legal advice or lobbying here. I also want to give a shout out to the co-authors of the Preemption chapter from the COVID-19 policy playbook on which this presentation is based. So Ben Winnig, Derek Carr, and Kim Haddow. To begin with, just so we're all on the same page, I want to set the foundation by defining preemption. At its core, preemption refers to when the law of a higher level of government, so a higher level jurisdiction limits or even sometimes eliminates the power of a lower level of government to regulate a certain issue. So that can be the federal government with respect to state and local. It can also be state government with respect to local, as you can see in this illustration. I'm going to really focus on the state-local relationship here today, but that's not the only place where preemption shows up. I also just quickly want to note that this issue is separate but related to the concept of local authority more broadly. So the amount of autonomy or authority that localities have really varies from state to state and is set out by state constitutions. But even in states where the Constitution gives localities a lot of authority, the state legislature can sometimes limit or remove localities' power to act on certain issues or even across a range of issues. There are a lot of types of preemption, and we've seen all of them as governments have responded to COVID-19. So ceiling preemption happens when a higher level of government sets a maximum standard, meaning that lower levels of government can't do anything more or different. And I'm going to come back to COVID examples shortly, but just to use a consistent, familiar example throughout, I'm going to use state level minimum wage laws. So ceiling preemption here would mean that a state could set its own minimum wage, but it would prevent localities from setting a higher minimum wage. Then we get to floor preemption, which happens when the higher level of government sets minimum standards, below which lower levels of government can't drop. So again, with minimum wage here, a state with floor preemption could set a minimum wage, but there they would allow localities to set a higher minimum wage, but not a lower one. And then finally, there's vacuum preemption, which occurs when the higher level of government sets no substantive standard and also prevents lower levels of government from doing so, meaning there's no standard at all. So here a state might preempt localities from setting a minimum wage while also failing to set its own minimum wage. So why do we care about preemption both during the pandemic, but also more generally? As a starting point, I'll say that preemption is just a legal tool. It's not inherently adversarial to public health, equity, or good governance. And if state or local governments enact harmful policies, which they sometimes do, or fail to address systemic injustices, preemption sometimes can be used in a targeted way to counter those actions and promote fairness and equity. So for example, here in California and elsewhere, the state legislature has preempted certain local laws, NIMBY laws, we would call them, with the goal of producing more affordable housing. But more recently, the vast majority of state level preemption that we have been seeing is problematic and really likely to harm public health and make health inequities worse. There's a couple of reasons why that is. Local policy is a really important aspect of our federalist system, and we often think of states, but also particularly localities, as so-called laboratories of democracy, where we can test out policies, see if they work, and if they don't, we can tweak them, we can gather data, and policy innovations that are working well can spread both vertically and horizontally to other localities and also up to states and sometimes to the federal level. And from an equity and community power standpoint, local government is really the one that's closest to the people and therefore potentially at least the most responsive and the most representative. When preemption gets in the way of that by stifling the authority of localities to act on issues, that can be problematic and lead to worsening inequities. So we're seeing state legislatures across the country using preemption in an increasingly dramatic and brazen way to remove local authority to regulate not just in public health, but in numerous areas that affect health. These efforts often are motivated by ideological and practical opposition to specific policies rather than any real need for uniform statewide regulation. And many of them are based on model legislation crafted by the American Legislative Exchange Council, or ALEC, which is an organization whose members include both corporations and state lawmakers. So preemption has long been something that we've contended with in public health, but this recent wave is really categorically different from what we've seen in the past. It's more extreme, it's wider spread, it's often punitive in nature, and it's often undermining the power of communities of color. And here you can see an example graphic from the National League of Cities across a number of different policy areas, including minimum wage, paid leave, municipal broadband, and more. And apologies, it's very small because there's a lot of detail on this, but what you can see is that many states, as you sort of go around that wheel, have preemption across all of those different areas. Here is another depiction of the same phenomenon from our partners and co-author at Local Solutions Support Center. And you can see this is a temporal depiction. So bills have passed on various topics over the last 20 years, but the graphic I think speaks for itself with the drastic uptick of preemption across a number of different policy areas just over the last 10 or so years. And here are a few of the troubling characteristics of this new preemption, including so-called Death Star bills and blanket deregulation, both of which take aim at whole swaths of local authority all at once, or punishment for cities or elected officials that do anything that even might be preempted, the inequitable impacts across various populations, the targeting of core local government functions, and the chilling effect that it has when there's such widespread preemption and localities just decide it's not worth acting. Turning now specifically to the pandemic response, we've seen a similar pattern of preemption play out and seeing it as primary problematic, though at times being used for good. So I'm going to spend the next couple of minutes diving into more detail about how preemption has come into play over the last however many months it's been now, year plus, and how it has impacted health equity in that context. So first, cities and states that had a lot of preemption already were starting from behind when the pandemic hit. So residents in those places didn't have access to policies that were really critical for ensuring equity in the face of a pandemic. You can see on this slide here again from our partners at LSSC that a number of states preempt policies that fall into that category. Paid leave is an obvious one that is needed in a pandemic, but also things like municipal broadband, which would increase access for millions of people that were suddenly faced with going to school or working from home. Existing preemption also stifled the ability of cities to respond quickly by enacting new policies that fell into preempted categories, like foreclosure moratoria or extra employment benefits for essential workers that did have to go into work. So this is preemption that wasn't necessarily directly related to the pandemic response in an infection control sense, but which existed beforehand and had an effect on that response. Some states put into place new preemption measures that were directly related to infection control, such as by preempting local mask mandates or other social distancing measures, or even more broadly, just preempting the authority of local public health officials. To return to the three forms of preemption that I mentioned earlier, we've seen them all. So in some states, governors issued statewide stay-at-home orders, but allowed local governments to implement additional restrictions based on local conditions. So that established what I refer to as a regulatory floor, meaning it didn't prevent localities from taking additional action to protect their residents. So for example, Louisiana's governor allowed New Orleans to lift and impose restrictions based on changing local conditions, recognizing the unique concerns of the state's largest city, which was also home to the state's largest Black population. That collaborative approach has not really been the norm. In a lot of states, Arizona, Florida, Georgia, Mississippi, South Carolina, Tennessee, Texas, West Virginia, and I could list more, those statewide stay-at-home orders were established as a regulatory ceiling. So they prevented local governments from imposing stricter requirements than the state. Take Arizona, where the governor there issued an executive order prohibiting any county, city, or town, so any locality, from issuing any order or regulation that restricted people from leaving their home due to the COVID-19 public health emergency. And some states didn't have any statewide home orders at all, but still preempted local governments from issuing their own orders. So that was the creation of what I refer to as a vacuum. For example, in Iowa, the governor didn't issue a statewide stay-at-home order, but she and the attorney general informed local officials that cities and counties lacked the authority to close businesses and order people to stay at home. In some places, we saw states go even further to actually punish localities that weren't compliant. So if you're following the news, you probably heard about Georgia Governor Kemp suing Atlanta Mayor Keisha Lance Bottoms when she enacted a mandatory masking rule and preventing that rule from going into effect, which they eventually resolved, but there was a lawsuit there. And in Florida, Governor DeSantis ultimately allowed localities to issue mask mandates, but his executive orders continued to prohibit localities from actually enforcing them or collecting fines for other COVID-19 related violations. Another means by which states punished localities was through threats of withholding funding in order to coerce them in various ways. In Nebraska, the governor warned local governments that if they wouldn't receive federal COVID-19 funds, if they imposed masking or other local rules. In California, that withholding of funding was used in a somewhat different way. So here, after Governor Newsom issued a statewide mandatory masking order, there were local law enforcement agencies that said they wouldn't enforce the order. And here, California said that localities that didn't comply with minimum statewide health and safety standards also were ineligible for $2.5 billion in state aid at the time for local governments. Unlike in Nebraska, California did not penalize localities that adopted more restrictive local orders. Governors in Illinois, New Mexico, North Carolina, and Pennsylvania, among others, also threatened to cut funding or take legal action against defiant localities. We're also seeing states wield power over localities when it comes to vaccinations. So for example, in Texas, the state threatened to cut the number of doses of vaccine given to Dallas when the city proposed a plan to prioritize the distribution in the hardest hit neighborhoods. Perhaps one of the most troubling things as we're moving from response more to recovery, we are seeing this alarming trend that will have profound effects moving forward of bills that are seeking to alter the nature of public health authority more generally. So these aren't all preemption. Some of them move authority, public health power and authority from the local to the state level, but others are more about reallocating power from health departments and mayors or governors to legislative bodies instead. So regardless of whether they shift power horizontally or vertically, many of them would make it a lot harder for local public health departments to act. And though some are restricted to emergency situations, some extend beyond that. And these could have implications for many years to come. Given all the information that I've just conveyed over the last couple of minutes, it's probably pretty obvious by now that in the context of COVID-19 and more generally, of course, preemption is most often standing in the way of local governments developing innovative solutions to advance health equity and improve health and well-being. For example, given the really stark racial and socioeconomic disparities in health outcomes related to COVID-19, which I'll point out are often directly attributable to racism and other forms of structural discrimination, state preemption of local preventive measures aimed simply at reducing the spread of disease, like masking requirements, almost certainly worsened existing health inequities. This is particularly true because we know that health status, including the existence of pre-existing conditions that worsen negative outcomes related to COVID, is intimately tied to where people live, to their zip code, and can really vary substantially over short distances, which makes the ability to tailor local responses really important. State preemption laws affecting not just the direct response, but the social and structural determinants of health also have likely created or worsened inequities. So governments at all levels adopted emergency policies like tenant protections, broadband access, paid sick and family leave, some of the things I've talked about. But as the pandemic subsides and temporary policies like those that were enacted expire, the existence of widespread state preemption means that those same populations that have been unfairly harmed by COVID-19 will again be unable to take any action to protect their health and economic security. The fact that many states prohibit localities from enacting policies across this broad array of issues means that millions of people, many of whom are from communities of color and low-income communities, have been excluded from the opportunities and health benefits that making these laws more permanent would provide. On the flip side, even in the context of the pandemic, there have been instances where targeted preemption has had the power to promote fairness and equity. That happens usually when local laws or local officials or community opposition has stood in the way of an effective response. So take, for example, localities that wanted to block testing centers or quarantine sites nearby, or localities that wanted to lift stay-at-home orders before state public health officials determined it was safe to do so. Similarly, statewide stay-at-home orders established baseline protections for all residents while allowing local governments to impose additional restrictions that address variations in local conditions. So that floor preemption we saw. Potentially helpful preemption notwithstanding, we know that the overwhelming majority has been an assault on the political power of communities of color, low-income communities, and other marginalized groups. So where does that leave us? And on this slide, you can see some of the means of pushing back against harmful preemption. And in the article, we also include some recommendations for action at every level of government, and there are a lot, but I'll touch on just a few here. So at the federal level, we can think about the appointment of judges who are receptive to legal theories that protect against the misuse of state and federal preemption, Or Congress could do things like adopt legislation that prohibits states from preempting local governments from building or expanding access to municipal broadband because they have authority in that realm. On the state level, we're really thinking about both preventing and repealing harmful preemption laws. And also repealing laws that are that penalize localities or local officials for even attempting to enforce preempted or potentially preempted laws. There are also judges at the state level that hear a lot of state law cases, and so those responsible for appointing judges and the voters in states where judges are elected can select judges that are receptive to legal theories that protect against the misuse of state preemption. There's also an effort underway, and the National League of Cities has put out principles of home rule for the 21st century, which really update the way that home rule and local authority would work. And legislatures and voters in states where voter initiatives are permitted can adopt some of these structural reforms. And then at the local level, we want to see localities supporting some of these state level initiatives. The other thing I want to point out is the bottom bullet on that slide, which is research. There's an opportunity for those who work in that realm to do some research here and to really document the real effects that preemption had on the pandemic response and to inform future policymaking in this space. Finally, I just want to point out some resources that we have at ChangeLab Solutions on preemption. They're available at the link on our website. They include a fact sheet on preemption generally, a paper that really dives into the relationship between preemption and health equity, and a toolkit on assessing and addressing preemption for local policy campaigns, among other things. We also offer technical assistance on preemption issues, so you should feel free to get in touch if you have questions. And my contact information is here. So while the current preemption landscape and that we saw during COVID is definitely bleak, it does provide an opportunity to bring this conversation about equity and preemption front and center so that we can really ensure that zip codes aren't actually dictating whether an individual, a family, or a community can achieve good health and prosperity. So with that, I'm going to pass it along to Dawn. Thank you.
Okay, let me see if I can work this. Okay, great. Hi, everyone. I am glad to be a part of this conversation today and close out the conversation with talking about lessons from the 2020 election cycle and how we can build a more equitable democracy. So I want to start out actually just talking about like what we know about the 2020 election. We had record turnout. People have heard that, 67%. Which was the highest voter turnout since 1900. And we had increased turnout over 2016 in all 50 states. 70% of voters voted early in person or by mail, which is huge. It was 40% in 2016. We had 28 states change their policy to make it easier during the pandemic to vote using mail-in ballots. We had 20 states with turnout over 70%, with Minnesota at the top with 80% turnout. And importantly, states that had the highest turnout during the election either sent all voters a mail ballot, have same-day registration, or both of those things. And then states with the lowest turnout cut off registration 4 weeks before the election or require an excuse for mail ballots, or both. The other important thing is that we had improvements of representation. We had 141 women, or 26.4% of Congress is women, a record 51 women of color, and 28% of the House is people of color, which is great, and great progress, but also still more work to do. Okay, so how does this happen? Like, what supports people getting out and voting and participating in elections? Well, a lot of the things on this slide here. So automatic voter registration, which exists in 20 states. North Carolina and New Mexico did it for 2020 only, but New Mexico is actually going to include Election Day starting this year. And then New York and Virginia will have automatic voter registration starting in 2022. Online registration, you think in today's society that everybody would have it online, but no, just 40 states, well actually 40, so that's most of the states, right, have online voter registration. Same day registration is in 20 states and the District of Columbia, and 18 of those states have election day registration. So same day is you can register and vote on the same day. So that means also in-person early voting, that you have that option. So pre-registration for 16 and 17-year-olds exists in 21 states. And early voting, 45 states have some version of early voting, but I put a little asterisk there because this varies significantly across the states. So there might be just a handful of days of early voting, and there could be 15 days of early voting. So there's a lot of variability there. No excuse absentee voting, which we heard about, of course, a lot during the election, 34 states. And then non-strict voter ID laws that are currently in effect, 26 states. And what non-strict means, according to a resource compiled by the National Conference of State Legislatures, is that if you cast a ballot and you don't have your ID or you don't have proper ID and it's provisional, et cetera, there's no further action really required on your part to count your ballot. The state, the local elections officials does something else. So as opposed to strict, where you have to take further action for your ballot to count if you have to cast a provisional ballot or don't have appropriate ID. So, but these are things that we know that promote turnout. So what are states doing? Well, states are not necessarily promoting those things, although some states are. So we're seeing a lot of good things and some bad things, right? So on the good side, we've got more in-person early voting. We've seen states enact ballot notice and cure processes, expanded eligibility for people with past felony convictions. Ballot tracking, right? Every state does not have the option to track your ballot, but it's certainly super helpful to make sure you know that your ballot was cast. Voter registration, Dropbox expansion. We heard a lot about that during the election. So we also have the flip side of a lot of these things, which is Dropbox restrictions and more voter registration barriers and more restrictive voter ID laws. But we also are seeing something very similar to public health authority, which is transfer of election authority. And then also this kind of creation of election-related crimes, which has been increasing in some of the more conservative states. Importantly, in many states, this is a mixed bag. So states might pass some aspects of election reform that are good and some that are not as great. And so as an example of that, Florida, where I live, we've gotten rid of a lot of things that made Florida a relatively great place to vote and easy to vote. But we passed a law that did a couple of things. It passed strengthened online and motor vehicle office or motor vehicle department registrations and updates, which is good. Also expanded pre-processing of ballots, also good, which we also did really well before this law was passed. But at the same time, Florida has limited third-party ballot return and has placed restrictions on the use of drop boxes. Florida also now requires a driver's license number, state ID, or the last four of your social in order to have an absentee ballot or request. And so what does that mean? If you don't have those numbers, then you can't vote by mail. So it certainly places restrictions on people who otherwise would have accessed that as an option to vote. So lots of state activity, also lots of litigation. And so I'm going to spend a little bit of time on this slide. So at the top is really a couple of cases and more cases besides these two that have implications for both redistricting and for ballot initiatives. So Moore versus Acosta and the Republican Party of Pennsylvania versus Buchbar are both related to changes that were made to ballot deadlines before the 2020 election or like while the election was ongoing. And really one of the most important things to come out of this is reasoning by the more conservative justices that the federal courts have some role to play in preventing state courts or other state actors from making changes to protect the vote under state law if those changes are inconsistent with the state legislature's actions. So, so what does that mean? Well, it matters for one really important reason, lots of important reasons, but one of those reasons is that there have been a number of past Supreme Court decisions that have upheld the rights of states to enact election laws through a lawmaking process, like ballot initiatives. So one key case there is Arizona State Legislature versus Arizona Independent Redistricting Commission. So that held that the use of an independent commission to adopt congressional districts is constitutional. So a potential consequence of this kind of new reasoning is that other state laws that govern the electoral process that were enacted through a lawmaking process, but not through the legislature itself, could be subject to challenge. And that's a question that's still unresolved, but the question about ballot initiatives is not in general, and also the fight against ballot initiatives in some states is not new. Just in the last legislative sessions for 2021, more than 125 bills were introduced in 31 state legislatures to amend or change the referendum or ballot initiative process. And this is significant because ballot initiatives have been used not just for voting, like early voting and ranked choice voting and restoration of voting rights, like here in the state of Florida, but also for medical and recreational cannabis, Medicaid expansion, and minimum wage increases, which you heard Sabrina talking about, really important. So there are really some unresolved questions regarding, the future of ballot initiatives. We heard Mississippi in the news recently, I think it was Mississippi, that the language of the requirements around their ballot initiatives for the number of districts that have to be certified is inconsistent with the number of districts that actually exist in the state. And so they've tossed out a couple of recent ballot initiatives, and it may impact others. So other cases I want to emphasize are challenges to the new voting laws that have been enacted in Florida and Georgia, and I'm going to assume also in Texas soon, since Texas has is pushing some of the same provisions. And the plaintiffs in this case are significant because these are all the people who are most impacted, right? So the NAACP, Disability Rights Florida, the New Georgia Project, Fair Fight Action, League of Women Voters, et cetera, other religious groups and voting rights organizations. And so what are some of the arguments that we're seeing? So in a few of the cases that I've looked at, one is First Amendment, free speech and free association. So what acts qualify as speech? Acts can qualify as speech if they convey a distinct message. And so one of the arguments is that giving out water and food and communicating with people about the importance of staying in line, which is now prohibited in Georgia and Florida, is actually communicating a message about the importance of participating in our democracy. So that's one challenge. We have 14th Amendment, unconstitutionally vague and overbroad. 15th Amendment, an unnecessary burden on the right to vote. Americans with Disabilities Act, failure to provide reasonable accommodations. And Section 2 of the Voting Rights Act, which is also incredibly important because that actually prohibits discrimination in voting, any voting standard, practice, or procedure, and that results in the denial or abridgment of the right of any citizen to vote on account of race, color, or membership in a language minority group. There's also an important case that kind of further clarifies this to say that the law or practice or structure interacts with social and historical conditions to cause inequality and opportunity. So the use of this Section 2 of the Voting Rights Act is important because of that, but also because removal of the preclearance provisions in Section 5 of the Voting Rights Act has kind of limited options to bring claims under the Voting Rights Act for discrimination and restrictions on the right to vote. So these Florida and Georgia cases include some Section 2 arguments, and then we also have a couple of pending decisions. We're waiting a decision in consolidated cases that you see here: the Arizona Republican Party versus Democratic National Committee and Brnovich versus Democratic National Committee, and these are both about ballot harvesting and also about the counting of provisional ballots that are cast out of precincts. But really, they're both about whether or not the state laws violate Section 2 of the Voting Rights Act. So those oral arguments were in March, and so we're still waiting to kind of find out what's going to happen with those. And that, of course, will have implications for these newer challenges to the recently enacted voting laws that we're seeing. But again, part of why these cases are being brought is because it's a burden. The argument is that these new laws are burdening people who have limitations on accessibility, transportation, ability to get ID. And the data tells us that that's people of color, people with disabilities, the elderly, and low-income people. So these are some significant cases to keep an eye on. So what else was happening in 2020? So you heard about threats to public health and elections officials and limitations on public health authority. And these are related because the exact same thing is happening with elections officials and election authority. So I kind of look at this as parallel attacks on two systems that are about the people. The collective power of people to determine and advance the conditions that make people and communities healthy, and really calls into question what does that mean about our system of democracy, and what does it mean for health equity? So we have threats and limiting or transferring authority, also happening for elections officials. And this report here actually is related to the Public Health Authority. It's recently released by NACCHO and the network on limitations. So if you haven't checked that out, check it out. The other thing that was kind of significant was also about the people, which is 2020 census and fair redistricting. Only 21 states have nonpartisan or bipartisan commissions for redistricting, and this matters because this is how representation is determined. And representation determines the distribution of power and resources in communities. And so partisan redistricting really dilutes the voices and power of communities of color in particular, people living in poverty, and other populations. And so, taking this as a whole, with what we have going on with public health and what we have going on with elections, I think we really have to ask, why are all these efforts occurring right now to diminish the power of the people? These things are not unrelated. So, but 2020 was not, doom and gloom necessarily. So there were some really good successes for public health, and that includes Medicaid expansion in both Missouri and Oklahoma. So now we have 12 non-expansion states, and from a health equity perspective, that matters because 60% of the uninsured adults in those states are people of color, 60%. Missouri actually has a pending legal challenge since the legislature refused to fund their expansion, and the governor informed the feds that the state will not be implementing their expansion. So I think a suit was recently filed there. But the federal government is really trying to incentivize states to expand. And so both the American Rescue Plan Act and the Families First Coronavirus Response Act contain financial incentives for states to expand Medicaid to the expansion population, and incentivizes some of traditional Medicaid by providing an additional federal matching rate. So other significant wins were minimum wage increases. You heard about that, but Florida is probably one of the most high profile by enacting a statewide minimum wage by ballot initiative. So that's significant, and that goes into effect in September of this year. We saw voter enfranchisement. We saw decriminalization of low-level drug possession in Oregon. We've seen taxes for public education and public transit, police oversight boards in response to criminal justice issues, and then paid medical and family sick leave, which we know was an important issue during the pandemic. So what are some recommendations? So the Biden administration, first of all, should develop an infrastructure to include voices from the community. So in general, all levels of government should have an infrastructure to include voices from the community in both policy development and implementation. So community members have to be involved in identifying what is a priority to them, and what are the best ways to implement that, and what are the assets that community has to help put forward to creating healthier, both healthier individuals and healthier communities. Also, the administration should invest in civic infrastructure and education, which they have done in part by issuing an executive order in March, the beginning of March of this year, to promote voter education access and participation through federal agencies. So Congress also should ensure sustained funding for elections administration. We saw that even though additional funding was put out to the states, funding actually came from other sources, private donors, foundations, et cetera, to help local elections officials. And perhaps most importantly is enacting minimum election standards at the federal level. That includes things that make it easier to register to vote and things that make it easier to cast a ballot. So state legislatures should eliminate felony disenfranchisement laws. Also set fair standards for drawing electoral boundaries. Right now is the hot time using the 2020 census data. Ensuring protections, importantly, for elections, public health, and other public officials. Updating state law for poll workers, right? So we saw massive efforts to recruit poll workers, increase incentives, and set standards for both polling place closures and consolidation, and increased use of vote centers, which was great. And then if the federal government does not take action, really states need to enact laws that facilitate voter access and protect the right to vote. And I just want to make a quick note that one way to set fair standards for electoral boundaries is not just through the use of these independent redistricting commissions, but also using algorithms or other objective criteria that preserve what's called communities of interest and ensure racial fairness, among other factors. So I'm not going to go into great detail on the For the People Act. I will note that if you're watching the news, you've heard a lot about this and you've heard a lot about the debate over it, but it does many of the things that I have talked about already that are recommended for improving access to the ballot. So creating automatic same-day and online voter registration, expanding nationwide early voting nationwide, so there's a consistent standard, restoring voting rights, creating no excuse absentee voting, And voter ID, of course, is controversial. Contrary to what some of the narratives are, it does not say that you don't have to have a voter ID. It provides an alternative for people who don't have the required forms of ID, so that we're not putting up arbitrary barriers to people being able to vote. And so for this last part of the conversation, I just want to talk about an initiative I'm involved in. So I'm happy to continue to promote the message of why elections are important, not just in a general, not just in a presidential election year. And so I'm a part of this group initiative called the Healthy Democracy, Healthy People Initiative. This is our website, which is getting ready to launch, hdhp.us. And we're really excited. And part of that is because we know that voting is important for health. And so you see this quote here, but we know that voting shapes who gets elected, what laws get enacted, and that all of these things shape the conditions in which we live, work, play, and learn. So everything that we know as the social determinants of health. And then we also know that when people vote and participate civically in other ways like volunteering, that there are many individual and community health benefits. So to approach this project very quickly, we did a lit review, and we looked at the evidence base for health and health-related indicators that are associated with voting or civic engagement. And I like to include this question in the middle, which is, would you say your health is poor, fair, good, very good, or excellent? This is a measure of self-rated health. It can be asked in different ways, but this is one of the most common indicators in the literature that has an association with voting. And so we also looked at the other indicators on the list here, including mental health, disability status, use of healthcare services, health risk behaviors, life expectancy, mortality rates, etc. So in addition to looking at health indicators, we also looked at some voting metrics like voter registration and turnout. And we also looked at different indices that assess different aspects of elections. And so the cost of voting index is one index that we looked at that was first developed in 2016, looking at presidential election cycles from 1996 to 2016. And it was most recently updated in 2020. And this is an excerpt here showing the cost of voting, showing the states ranked by their cost of voting index scores. And there's the reference for the most recent article on this. From the Election Law Journal. And importantly, this index measures the relative restrictiveness of each state's electoral environment. And it's developed using what they call a principal component analysis that looks at 9 issue areas that are related to both registering to vote and then casting a vote, which I mentioned earlier as two areas of kind of intervention for increasing electoral participation. So what did we do? We combined the cost of voting with health indicators, and we get what you see here, connecting the data. And so what we did was we looked at voter turnout, self-rated health, mental health, percent of adults receiving disability benefits, which you see on this slide, and percent uninsured rate. And then we sorted the data for each of these indicators by the cost of voting index. And like the most absolutely incredible thing is that on average, states that have the least restrictive electoral environments have across the board better individual and community health outcomes than the US average. And the reverse is also true. So states with the most restrictive electoral environments have the worst health outcomes. So some additional indicators that we're looking at are active physicians per 100,000 population as a measure of health access, chronic disease prevalence, premature mortality, infant mortality, and poverty. We also are including community and family safety rankings, which isn't shown here. And all of these are averages, of course, so there are going to be exceptions to the states in these groupings, but you'll actually be able to see when we launch this scorecard, you're going to be able to see state-specific data. And so, but it's really stunning to look at just across all these really important indicators of individual and population health, the correlation with access to the ballot. So I'll end with what are we doing about this? So we are creating the Health and Democracy Scorecard website and launching the Healthy Democracy, Healthy People initiative. We're going to be engaged in Civic Health Month, which is August. And we hope to engage civic health champions and equipping people to get out and help advocate for voting as a way to advance health equity. We also have been participating in a call to action, one, to restore civic participation to the Healthy People 2030 leading health indicators. It was in Healthy People 2020 and did not get included in 2030. The other thing is we are requesting the administration to provide clarification on automatic voter registration through the Medicaid program by clarifying guidance to states on using Medicaid data for voter registration purposes. And so a lot of the information that I've shared with you today comes from some of these websites here. The National Conference of State Legislatures, Nonprofit Vote, which put out a recent report, America Goes to the Polls 2020. It's a great report. The Voting Rights Lab just, I think, last week issued this report, A Tale of Two Democracies, that goes into a deeper dive in some of the legislation that has been introduced and enacted. The Brennan Center, of course, is always a really great resource. And that's it for me. I'm really looking forward to the conversation in the Q&A, and I'll turn it back over to Kathy.
Thanks, Dawn. I'm actually going to ask you 2 technical questions real quick that came into the Q&A. It's so funny because we're used to having to explain acronyms that we use in public health or the like, but these were election type questions. So what is ballot curing and what is ballot harvesting?
Thanks. Good question. I know, right? It's like I should not assume that people know what those terms are. So ballot curing is fixing your ballot if there's something wrong with it. So for example, your signature doesn't match or you forgot to sign your envelope. Many states have a process by which you can fix that. And so you can go back down to the elections office, sign your ballot. Sometimes you might be required to cast a new ballot, destroy the old one, etc. But it's an opportunity to fix your ballot. And ballot harvesting is really, actually I don't really like that term, so I don't know why I used it, but it's really basically, you are in many states able to collect ballots for other people and return them. And so many states have been enacting laws that restrict the number of ballots that you can return or restrict who you can take ballots back for. So maybe limiting to, members of your immediate household as an example. So that's what ballot harvesting refers to.
Thank you for those clarifications. A reminder to folks, you can use the Q&A box to ask questions, but I'll start it off with one for Sabrina. What, if anything, can local health departments do to help mitigate the changes or attacks on public health measures, public health authorities?
Sorry, I was trying to get myself off mute.
Gotcha.
That is a great question. We are working with a number of partners, Local Solutions Support Center, who I mentioned in my presentation, the American Heart Association, the network, et cetera, to help provide technical assistance to folks that are facing these attacks on public health authority in their states. So number one, I would say, is get in touch, because I think part of what we're doing is first analyzing the bills to help understand what they're actually saying and what the implications would actually be, so we can understand sort of the pros, but mostly the cons, because there aren't a lot of pros in many of them. But then also hooking people up with others in the state, particularly those who may have more experience lobbying or pushing back against preemption bills or some of these anti-regulatory grabs, and figuring out sort of what the best plan is. So we don't lobby. Like, our role in that is to really figure out like the analysis piece, like just figure out what some of these bills are saying, but we work closely with folks who have a lot more networks on the ground and have people in state houses, et cetera. I think the other thing is just to advocate within your local health department for getting involved in figuring out what's going on the state level. I think there's a general sort of, for good reason in some cases, not like resources, sort of fear of lobbying, et cetera, to shy away from some of the big P policy work that's happening on the state level. And there may be sort of a disconnect between what's happening on the state level and localities. But if there ever were a time to pay attention to state level policy and sort of talk to your colleagues and other local health departments in your state to sort of come together to keep an eye on what's happening, now is that time.
So I think really it's kind of a follow-up, but I want to, have each of you answer, and whoever wants to jump in first. But we did it in alphabetical order. I was going to go to you, Abby, but you guys can decide. But it really does tag on to your answer there, Sabrina, and that is, I think it's a valid question of, we're so used to public health being local, right? That's when we think it's best, at its most innovative. We recognize there are times the state's involved and the federal government's involved, but predominantly at the local level. But COVID has kind of turned that on its head a bit, and we have looked to the federal government in many ways to help address, ameliorate the impact of the pandemic. What do you think? Do you think there are any kind of long-term ramifications of that might reduce local power, or has there just been a power shift or a dynamic shift at all in that federal, state, local kind of control of public health?
Yeah, I can start since I start with A. I think it's interesting. I'm not sure if there's been a power shift or just a perception shift in the visibility of actions. I mean, we all have been kind of looking to the federal government for guidance, and we've been hearing a lot about state actions, but I don't know that there's been a power shift and that power has necessarily been taken away from local governments. But I'm certainly interested to hear what our other panelists have to say about that. And I noticed that Peter has joined us, so I don't know, he may want to weigh in. Or he may not, I don't know.
Sabrina or Dawn on that one?
Yeah, I think there's actually this really interesting battle right now over power, right, at the state and local level, and states really being unhappy with localities kind of doing what they needed to do to best take care of their communities and wanting to exert more control over what happens in their state. And I definitely am one of the people who agrees that, being able to take action at the local level is the way you can be most responsive to the people in your community and tailor your interventions appropriately. And so I actually also, I appreciate Abby's comment. I actually do think that even if actual power hasn't shifted like on paper, I think perceptions that power has shifted is a power shift because it shapes how we interact with our institutions and with each other. And I do think that this narrative around the need to shift power to the legislature or to the governor is really kind of winning, the winning argument at the moment, unfortunately. And so I think we have to do a better job, messaging about the value of public health and the importance of public health and the importance of local involvement and community involvement, that right now we're just not really winning that conversation.
Sabrina, anything to add there?
Mute button is being very sticky. Not a lot to add. I mean, I agree with all of that. I think, this is also a reflection of just a broader politicization of like everything that we are seeing. And there's a lot of like, which level of government is going to get us the outcomes that we want to see. And, people want vaccines, but they don't want to stay at home, or maybe they don't want vaccines, but some people do. And sort of where can that be best accomplished? And there's also just the nature of this particular public health emergency that we've faced in over the last, whatever, many months, again, lost track, but that, this has hit every state, every locality around the country. And I think people look to the federal level when there's something that they're seeing everywhere for like, help us all or don't help us all, whatever it might be. And then sort of want to tailor solutions accordingly, keeping in mind that like next time there might be a measles outbreak that's just in one place, and now you've taken away the authority of that locality to deal with that and sort of place that in a different level of government, and that becomes like highly problematic. I think we saw the federal government stand up for like help us in some ways and not help in many others, like through much of this. So
yeah, I mean, my 2 cents added just relates to kind of what you said toward the end there, and that is, I fear there is this desire to say, this was a crisis, and stuff went poorly. Some stuff went poorly. I think by and large our local health departments did a phenomenal job on super stretched resources, as did our state, many of our state health departments. But so the thought is, well, change now the power. Who gets to decide things? Who's getting these resources? Instead of looking at why some of the response wasn't as, fertile or wasn't as vibrant as it could have been. Maybe it's because public health infrastructure has not been focused on in this country. And instead of saying, oh, we're taking it away from you because there were some either mistakes made or insufficiencies, which naturally would have happened in a pandemic, and put it somewhere else, let's say, what worked well? 75% of this worked well. Let's work on the 25%. So my 2 cents. Peter, I saw that you joined us. Did you want to add any comment?
If I can get through it, sure.
We can hear you.
Thank you. Very quickly, I'm not sure we know the answer yet. We know that certainly both the perception and the reality have changed. Unfortunately, focusing on the wrong problem, Kathy, as you were suggesting, that is, some officials took a once-in-a-century pandemic to undermine local health department. Whether that's sustainable is the question I have. I don't think it is, for a lot of reasons that go well beyond, I think, the topic of the webinar. But in short, routine preparedness is likely to be the focus over the next decade. And the question will be whether these laws have effectively undermined local public health in some states, or whether people will realize that they went too far based on the pandemic, not thinking about the effects of the day-to-day responsibility as health departments, local health departments have.
Yeah, absolutely. I totally agree with you. And like, I don't want to wait and see. I just hope the answer comes, that we can do a self-correction. But that leads me back to the polling place, right? To Dawn's talk about, what the people's voice is as expressed through the polling place. So Dawn, there's a question for you in the Q&A, so I'm going to read it. Thanking you first for your presentation. How much evidence is there to show that access to voting / civic participation alone improves health? Correlation versus causation. For example, are states with the least restrictions on voting, I presume here, also the most likely to have better social supports, laws and policies that advance equity, or does access to voting alone also improve health? So I think it's isolating that, how do we know that the voting has any impact, or is it just coincidental that the states with the most open and accessible election laws also have other social supports and otherwise that lead to healthier communities? Thoughts, Dawn?
Yeah, so first is that what we know from the literature is that these things are correlated and there's not necessarily a causal link, right? So there's definitely more research needed in this area, and I would certainly advocate for that. We also can only really link things from the research at a high level. So voting, volunteering, civic participation. We can't, though, say if you have automatic voter registration that you have better health outcomes, or if you have, mail-in ballots, no excuse absentee ballots, that you have better health outcomes. We don't know that. So certainly I think that there is an area of opportunity for research. And then I would say from a legal epidemiology perspective, what I would love to see is what we have all these, we've had massive changes in election law, I think massive, in the past legislative cycle. And so it would be great to actually monitor over the next few years, because we know population health takes time to show change, right? Is to say in these states where these more restrictive laws were enacted, did that affect health outcomes in particular communities in the state or in the state overall? So unfortunately, not enough information now, but definitely I think people are wanting to dive into this more deeply and do some more research on the connections.
Thanks. Another one in the Q&A that relates to the question we had right before that one. It's just interesting, so I'm going to throw it out there. Some countries, Switzerland, I think, says Ken Gatter, have a system of shifting levels of authority. For example, early in the pandemic, it's federal, but gets more local as time moves forward. Is this desirable, or would it even work in the US? I love these kinds of questions because they are, in some ways, purely academic, but with real practical implications. Anyone have thoughts on that?
I actually have one thought about it, because I studied for a while how the European Union countries provide public health services. And in many of the countries, and I think Switzerland included, there's an intermediate level of government between the federal and in Switzerland, the canton level. And it's an opportunity for an independent review of local and a way of communicating up between federal and local that we don't have. And it seems to work in these countries because it's an opportunity for our equivalent would be the national public health organizations to play a more substantive role in these kinds of issues.
Thanks, Peter. Anyone else on that? I have another one I can go to. I love those kinds of questions. So let me think. Another one just popped in. So lower levels of government often rely on resources from higher levels, but these funds are often restricted or contingent on other factors. How does this funding process relate to the preemption equity conversations? Is it even reasonable to expect the state or federal governments to provide blank checks to local or state governments?
So I can start out. Yes, that's true. That funding is often contingent. There's conditional funding all the time. There are limitations on what conditions you can place, and I could go down a rabbit hole with that. But it's certainly related to the preemption and equity conversation. It's not quite the same as preemption, like definitionally, but is it reasonable to expect blank checks? I mean, I think that depends on your point of view. I think some people would argue no, it's not. I also think that if you're focused on equity as an outcome, and then you're looking at states that are, or the federal government sort of using that carrot, if you will, you could maybe call it a stick in some ways, depending on the setup, but to basically incentivize localities or states to do things that are harmful from an equity perspective, then I think that makes it problematic. But I don't think like across the board funding with conditions on it is like per se a problem. Similar to preemption, it's a tool that is used to sort of organize the relationships and activities between the levels of government, and it can be used both for harm and for good.
Anyone else? Thoughts on that one?
This prompted me to think about, not emergency funding, just ordinary grants from the federal government, and just going to state and local health departments. And so that funding often has really strict evaluation requirements and reporting requirements. And then, I'm a huge fan of evaluation and reporting, but I also think that eventually it just becomes checking a box, like reporting for the sake of reporting and not because you're actually sharing useful information. And from an equity perspective, I think, what we hear is that, number one, not enough funding goes to like offices of minority health or other offices that are dedicated to addressing health equity issues, but also, these restrictions in terms of evaluation. And then also often there are requirements for an evidence-based or best practice that we just don't have for communities of color necessarily, or other populations that are disproportionately impacted by a given health condition. And so that means that, many opportunities to fund really innovative public health, at the local level are restricted. And so my hope is that, post-COVID, that we really think about the way that funding is given out to the states, not just where it goes and what offices and departments it supports, but also what the requirements are back to, the funder in terms of reporting and collecting evidence and sharing evidence and requiring evidence. And so being a little bit looser with those restrictions to really support kind of health equity in communities.
Anyone else? And I think there also can and should be a call to action from philanthropic organizations. I recognize we're going to see slow progress, if any, on this issue of restricted funding coming from state or federal, entities, but that's where large nonprofits working in the health space, or large nonprofits working in any space, need to recognize that health touches on no matter what your interests are, and really look at ways that you can enhance the funding that is coming, and really doing that not through here's a shiny nickel, work on this particular issue, or you can work on this issue but only in these ways, but really giving either infrastructure dollars or more broadly accessible dollars to state and local public health entities. So cheers to that. Another
Kathy,
question.
Can I just add really quickly? I mean,
please.
I think that applies to elections as well. I mean, philanthropy, right? Just thinking about not having a sufficient funding from the government, I mean, we still found a way to have a successful, secure election. And it was because, you know, that we had funding from other sources. It was because we had these nonprofit organizations and foundations, you know, stepping in to help out local elections officials. And so I think, you know, the same thing applies for elections as for public health. You know, these things that support the community and support people's participation in a process to create better outcomes. Doesn't have to all come from the federal government, right? We have partners who can help move this along.
Diversity and funding, always. And that's just always going to make for, you know, kind of better outcomes. But that relates to the next and, you know, potentially last, depending on how many minutes it takes to answer this, because I know it's a good one. What are some examples that we can all get involved in to support our community and individuals who are rebuilding and developing those local protective factors? Other than, we just said, funding through, you know, your local nonprofits, national nonprofits, whomever. What can we do? What can folks working in public health do, but as individuals in the community as well?
I can start. I think, you know, as someone mentioned earlier, it's important to get involved at this point in your government. If you're concerned about equity issues, I think it's important to go to your, as community members, to go to your local Board of Health meetings and to express your concerns about it. And just let your communities, the leaders of your communities, know that that's something that the community wants, and call attention to it.
Yeah, 100% on that. I mean, but I would say it's not, you know, it's everything. It's get out and volunteer, go to city council meetings, vote in all local elections, write an op-ed.
Run for office.
Run for office, yeah. I mean, and listen, everybody, anyone, you can run for office, right? There are organizations out there that will support you to do this and identify the best position for you, right? They'll help you figure that out. These things are all really important, right? We know that the more engaged people are, that we have increased social cohesion, and increased social capital. And these are things that, of course, create healthier communities. And so, you know, even one small thing, doing your part, helps to create a stronger community. So I say, pick one of those things and do it. Get out, find a way. You need ideas, I've got them. Let me know.
Sabrina, Peter?
I also think, you know, I'm certainly not the first to say this, is I will just echo what has been said throughout this pandemic, which is that no one pays attention to public health unless something's going wrong. So I think, you know, now there's this like focus on public health, but maybe the general public's interpretation of that focus is a negative one. And I think both for folks working within health departments and out in the community, sort of taking the opportunity to reframe and talk about the potential for public health to do good, both, you know, related to this emergency situation that we've found ourselves in, but in the longer term also. You know, there's like, I love Dawn's focus on voting and civic engagement, because I think, you know, 10 years ago, no one would have thought of that as a public health issue. And there are so many of the things that are deeply impacting communities that we might not have traditionally thought of as public health. Like, now those connections are becoming ever more clear as a result of what we've just all gone through. If they weren't clear, you know, they may have been clear to those of us in that field for a while, but I think that's becoming more and more clear to people more broadly, or at least it now is an opportunity to make it clear and sort of capitalize on that and translate it using some of the mechanisms that I think Dawn and Abby were just talking about.
I totally agree. I think there has to be rebranding in the big level and on the micro. And when we think about how we talk about, you know, what our local health department does, well, it shuts down restaurants that violate the food safety code. Well, why don't we talk about them actually making sure when you go to a restaurant, you have food that's safe for you to eat, right? We often talk about what they do in that negative instead of the positive health affirming, you know, impact of these kind of, you know, powers that they have. And so I certainly think some rebranding. If only Gene Matthews were here to talk about his better messaging, we'd have a full slate. Peter, did you have anything to add?
Yeah, I have two, probably more or less controversial suggestions, really following on what you just said, Kathy. The first is that I'd like to see consolidation among the national public health organizations into one overarching public health organization that can speak with one voice to the politicians, to Congress, to governors, and represent public health. At this time, my sense is that it's a fragmentation of messaging, and as a result, a diffusion that has little or no influence politically. The second is putting on my former Board of Health hat, if you will. And this gets something that Don was talking about earlier, and that is the state's requirement that local public health consider a certain number and specified services that need to be provided. I think local communities need more flexibility given the funding, that it's not just the funding, it's a requirement of providing services in a uniform way when we know that the states differ across communities and each one faces different problems. Providing flexibility has some problems. For example, in some areas, you're not going to have any attention to equity. In others, you'll have a lot of attention to it. But I still think that there's a benefit to giving the local health departments more flexibility, because that's where public health is provided.
And I think part of that, allowing that more flexibility can and should come in shared resources. And, you might have 3 tiny jurisdictions that want to have their autonomy and decision-making power, but they can't really staff for every position for which the state, is funding them to cover. But if there are better methods for coordination and collaboration across jurisdictions, that's a win-win, right? Everything's covered, but in a regional way, perhaps, instead of on a county by county basis. That's certainly something that we at the network, and I know Change Labs as well, can provide support to communities who are thinking about ways to make that happen. So I think that's a terrific suggestion. So we're running close on time. So I just want to ask actually everyone on the presenters, including Peter. Thank you so much for joining us, Peter. I know you're not feeling your best. Anyone last comments before Charles takes it away?
I want to say something really quickly if I can.
Yeah.
Peter, I love the idea of this consolidated public health organization. I think one of the things I lamented often when I worked in state public health is that I would be involved in all these different projects sponsored by different organizations, and they would often be very similar, and there was just no kind of cross communication or integration of efforts. And I really do believe in collective impact. So, I think that we are stronger together, and we can amplify each other's work and find new ways to do things when we partner. And so I love that concept. I'd love to talk about that with you more. The other thing I would say, specifically from being engaged, is think about your local health. A lot of jurisdictions right now are issuing racial equity action plans or something in response to, addressing racism as a public health crisis. So whatever community you live in, find out if you have one of those plans in place. If your jurisdiction has a declaration, what is your health department doing? And can you get involved in the process? So the community health or state health improvement process, being a part of developing the racial equity plan, being a part of community conversations. It's really important that the community voice is uplifted in developing these action plans. So I would encourage you to kind of find out what's going on in your neighborhood and get involved.
Thank you, Dawn. Others?
Just to
Go ahead, Sabrina.
Okay, I related to public health authority, I would say, now we are playing a lot of defense, and there's a lot of fires to put out related to this sort of attack, I'll say, on public health authority. But I think there's also an opportunity to think about what we'd want the offense to look like. And to the extent that there might be some restructuring of how that authority works, and how, we've talked a lot during the last couple of minutes about how money flows, how power flows, et cetera, to be on the front end of things and put out proposals to make the system work better, rather than just sitting there and sort of defending attacks against how it's currently working. So that's maybe a longer term effort, and we probably won't be able to do the offense without first playing defense here, but maybe an opportunity to sort of take a step back and think about, like, how do we want power? Who do we want to have power? How do we want the money to flow, et cetera? And have a conversation about that and maybe do something about it too.
Thank you, Sabrina. Peter?
Until we build a public health voice, nothing will change.
Well said. Abby?
We've kind of skirted around this issue, and it goes hand in hand with public health messaging and building a voice. It has to be a voice that the people can trust. Trust has been shaken in public health as a result of this pandemic, whether fairly or unfairly, whether the fault of the federal government or local governments. And before public health can kind of gain back the offensive and be successful, we have to find a way to make us more trustworthy.
Thank you, Abby. And thank you to all the presenters. And Abby, the best of luck as you continue with your bar preparations and taking the exam, and your career as you progress forward. So on that note, I'm going to turn things back over to Charles.
Thanks, Kathy, and thank you to all of our great speakers for your insights today. Just a few final notes. All attendees will be receiving an email from the network with the materials from this webinar, as well as a link to a really quick webinar survey. It takes just a minute to fill out and provides us with some really great insights. You'll also be receiving an email from ASLME with information on how to apply for CLE credits for this event. And finally, join us this Thursday for a webinar where speakers will examine state laws protecting public health officials from harassment. You won't want to miss it. So that concludes today's webinar. Thank you all for attending and have a great rest of your day.
Thank you.